General Hospital. So how are we going to do these things? How are we going to, in Thames and Dorset, can we improve methods? How are we going to improve knowledge? How are we going to improve pathways into care, if you like? And how are we going to improve service in the community, servicing old people's homes, servicing general hospitals? Those are the sort of big questions, I think. The greatest news in Thames and Dorset was that last week, I've been here 3 years. Well, you might think. After 3 years, for the first time, there was a meeting called DCAF, that's a cool name, isn't it, DCAF, of organisations and people that care about dementia, yeah, across the board. But it's particularly for carers and patients, but it involves the local authority, it involves the Alzheimer's Society, it involves Age Concern, and it was at Age Concern on Catherine Street. And that's going to go on every month. It will be a meeting on a Wednesday. I think.
And that's Wednesday in the month.
The last Wednesday in the month.
Yeah.
What time is it?
2 o'clock. 2
It was 2 o'clock last week. So the last Wednesday, every month, Age Concern, come along and so, because I think what we will develop there is a focus of all the people who care about, who know about this condition, and can help commission of all sorts and all of us practitioners to know what people really care about, so that we've got the sort of messages that are coming from folk here tonight translated into a regular activity that provides a forum of knowledge that can interact with what we're all doing. I mean, it's great listening to people presenting, because people are busy, aren't they? People are trying very hard in their various ways. And it needs something like that, I think, a forum, a group of people who know that condition, to help mould it into the most productive shape.
It's probably worth saying that didn't cost anybody any money. It's actually been generated because people wanted that to happen and made it happen despite all the obstacles in the way. That's been made happen by different organisations actually working together at no cost.
Okay, that's good news, isn't it?
Absolutely, that's really good news.
Okay, shall I sit down?
No, well, I was going to just open it up to questions and answers, really.
Dr. Dolly,
Yes, dear.
are we aiming here and getting the Admiral message in terms of...
One of the things that I haven't mentioned is the absence of Admiral nurses in Thames. But the presentations have said, I'm there, I've got my husband or my wife with dementia, and it's a journey through, isn't it? And sometimes it's short, over months, but often it's years and years, and things change over time. And what people always say is, I need somebody to be with me. I need somebody to be with me. And how can you do that? How many people are there with dementia in Thames and Dorset? Well, of the order, well, over 2,000. Yeah, say 2,000. It's a lot of people, isn't it? How many have you got on your practice register? Come on, go press a button and find out.
I have no idea.
16. Probably 16 or something like that. 16. So that's not too many, is it? So we could ask the practice to do the follow-up. That's what we do in NOSL. It can be done, I think, for many people in a practice that knows the person. And sometimes it's a particular GP. In NOSL, it's a health visitor that's identified as the dementia champion, if you like, within the practice, etc., and so on. But sometimes it's very difficult, you know. And what I'm very concerned, if we can, to have primary care activity for people with dementia, the secondary care that we're involved with. Because Steve Iliff was talking last week, and he talked about common things occur commonly and can be managed. These are in general practice happening here. Uncommon things do occur. That is, difficult things do occur, and you need a bit of extra clout and so on. So I think a lot of supporting and parenting can be done by families, by general practice, and by other codes. But some people, it is difficult. And this marvellous organisation of Admiral Nurses has been created. This was a family in North London where Dad had dementia, and the family said, well, we think he's been quite well looked after, but we're wrecked. We don't know what to do, we don't know how to feel about it, we have these emotions, and so on. And so they created the first arrangement of a nurse whose specific responsibility was to for the carers, for the family, and also to act as a resource and an informant for the rest of the community mental health team, for instance, to work in a similar way to provide that care and support. I mean, that organisation is now under the umbrella of 4 Dementia, which is, you know, and they have got a national profile. People like George Melly. Do you remember George Melly?
Yeah.
George Melly, great, just thinking, had a dementia, probably vascular dementia, was dying of cancer, but his wife said, I don't care about that. It's the fact that he doesn't recognise me, and he does all these strange things, and that's what's killing me. And so she became involved and helped them make quite a lot of publicity, and other people have done that through this year. So we're dead keen, yeah, we are very keen indeed to have Admiral nurses as part of the spectrum of support, and I know that you've had that experience in Manchester.
Yeah, you're a lifeline for me.
Yeah, the amazing Pam Kehoe, who's currently our community modern matron, you see, working in
we miss her. Tell her we miss her if you see her.
Can I just ask, we've got a couple of managers or nurses working in the nursing homes. What about your thoughts? We've talked about general practice and we've talked about hospitals, but what about the nursing homes themselves? Anyone here from a nursing home who'd like to make a comment, or is it going well? Is it going not so well? Are there things that you've heard today that give you enthusiasm and make you think your life's going to become easier, or?
Dr. Anna, I'm just wondering about the dementia review. Does it have to be done every 12 months? Can it be done 6 months or anything like that?
I think the truthful answer, well, there's the official, what's expected in the NHS, and I guess it's the question of, you know, who pays for it.
Right.
And if it's a payment question, then it's once a year. However, we're not here about money, we're here about delivering good quality care. And I would argue that, and I'm sure David, you'd say the same, that it's much about the function of the individual. If the individual's function appears to be deteriorating and there seems to be a depreciation going on, then we need to know about it. Well, how are we going to know about it? Well, we need to review that patient and continue to review them. So it should be variable, and that's my thoughts. What do you think, Dave?
Well, as you know, some people think that I'm a very strange person, because when I came here, I decided, I didn't decide, I knew that what I had to do was go and see people at home to start with, and I knew I had to follow them up till they die. And follow-up means you see people at least every 6 months, because otherwise they forget who you are and you lose away and things like that. So, yeah, I mean, once a year monitoring, which is to a point what we are achieving at the moment with the benefit, is in terms of clinical care, it's rubbish. It's all but meaningless. And that's what my question to the lady with the computer, what's it for? Just filling in boxes and all that. No good use to anyone. So some people need much more frequent. I mean, I see some people every week for a bit, and the nurses do as well. But then you monitor before opening it out. I mean, the least frequent, 6 months, and really 3 to 4 months is a better loop system. But that's intensive manpower, person power, intensive, and how we model it. Because if we can get down to talking about that, you know, some of that, a lot of that can be done in my view within general practice very well, very happily, and that's marvellous. And we, the so-called specialist service, involved with more complex, difficult bits and pieces, then perhaps it can come back to primary care. Because in the end, most things are carried in primary care, and we're just birds of passage only. We shouldn't look on ourselves as piglets, taking people away to another world. Because people live in Hyde, Glossop, where are we? And this is where it is. So, but yeah, I mean, you've got to be seeing people all the time and listening all the time.